there. But hopefully I'll make it really easy for you. So I'm going to talk a little bit today about a study that I did years ago with some of my colleagues in Hamilton, Jeff Norman, Amir and Gaffney, and another colleague in emergency medicine, John Charbonneau, who was the architect of what's now called Competency-Based medical education in Canada. One of the big things that we were interested in was, why do physicians not adhere to guidelines? And there are some obvious reasons why that is the case, but we're trying to get a little bit at some of the lesser thought about ones. All right, so I'm going to start off with a clinical scenario, as I guess often happens when you're talking about guidelines. So suppose we have a patient, Mr. Laurie, he's a 21-year-old man who presents with trauma to his right ankle. This is presenting to the emergency department. And he did this while skating into the corner during a hockey game, and he was checked to the ice and twisted his ankle. So it's with past medical history, nothing really of importance, medications, he's taking some vitamins, and then there's some vital signs here. Everything seems pretty normal. So on the physical exam, we find that Mr. Laurie is able to walk into the exam room, although he has a slight limp. The neurovascular exam of the foot and ankle is normal. There's considerable swelling in the inferior medial malleoli. And for those of you who don't know what these terms mean, I'm going to show you a diagram in a second. The area, so this area is tender when palpated. However, there is no reproducible or obvious point tenderness of the medial or lateral malleoli. There is no proximal fibular tenderness, and the metatarsal head and navicular bone are not painful to palpation, right? And so the question then is, would you order an ankle x-ray series on this patient? And I see some people shaking their heads, right? And that's probably good. And so why are you shaking your head? Because you have a guideline for that, right? It's something called the Ottawa ankle rule, right? So the Ottawa ankle rule is a little different than a lot of the guidelines you're used to seeing over the course of the last few days, because this is really tailored towards emergency medicine, who they don't really like to spend a lot of time reading, and they do like to spend a lot of time doing. And so they want their rules to be really, really to the point. And so you only x-ray an ankle if you have some bone tenderness in this area here, or in this area here, or the person has an inability to bear weight, both immediately and when they're in the emergency department. All right. Sorry? You guys can hear me okay?
Yeah.
Okay, sorry. And so if you don't have any of those, you don't x-ray. This is a very, very good rule, at least by the standards of current clinical science. It has been reproduced in a number of different environments, a number of different countries, different patient populations, has very high, what we call sensitivity and specificity, meaning that it probably won't let you go wrong if you follow this rule. In fact, actually, I was going to show a text message of when I sprained my ankle about 2 weeks ago, where I texted a friend of mine and I said, I rolled over my ankle in the garden, and he said, do you have bone tenderness here? No. Do you have bone tenderness here? No. Can you bear some weight on it? Yes. And he says, I'm happy to arrange an x-ray for you because I know you're a hypochondriac, but Ottawa ankle rules rule, is what he said in the text message. So that's where we're at. But, so the decision to x-ray is easy, right? We got a rule. Problem is that what we find in our emergency department is not everyone who needs one gets one, and not everyone who gets one needs one. So it's obviously not clear. Something else is going on. And we were really, really interested in getting to the bottom of that. Now, incidentally, I tried doing this in other jurisdictions. In family medicine, I tried to do what I'm going to show you here. I tried to do it with cardiology. And it turns out that every time you ask people these kinds of questions, they always say, well, it depends, right? There's a lot of depends. Whereas emergency medicine physicians were very, very happy to say, this is what I'm going to do, this is not what I'm going to do. So they were a perfect perfect group of people to look at these things. All right, so the first thing we have to ask ourselves is, why do some physicians not follow the guidelines? And so we get this great study by Cabana et al. In JAMA in 1999. It's got 5,000 citations, and it's a systematic review of all the studies that look into barriers and facilitators to guideline adherence. And of course, right off the top, you get the obvious ones, right? It's the doctor, right? Physicians are doing things. They're either don't know about the guideline, or they're not familiar enough with it to implement it in practice, or they don't agree with it, or they don't think that they could actually use it properly, right? Their outcome expectancies are different than they're saying, well, this is fine, but this is my patient, and I don't care what the guideline says, the outcome I'm going to get is probably going to be different than that. And then there's also this inertia from previous practice. I've always done it this way. It's always worked well for me. Why am I going to change my mind now? Buried deep into this paper, you also have something called external barriers, right? So these are things that are related to the guideline. It's hard to get, right? Hard to look up when I'm in practice, whatever, right? You have these environment-related issues. They could be problems at the hospital, not wanting to use guidelines, whatever the case may be. And then we've got this patient-related one right at the bottom. Not a lot of attention to patient-related factors for why we don't follow guidelines. And that's what I'm going to spend a lot of time here talking about now, right? So right off the top, we can think of one good reason why that's related to the patient why you wouldn't follow a guideline. And this is a medical exception. So what do I mean by that? Well, following the guideline is contraindicated because the patient has comorbidities, or there are other therapies that actually would interact with the therapy that you're giving in such a way that you think you're going to get a bad outcome, right? So Purcell et al. Did this wonderful study where they demonstrated that this is actually something that happens, right? So what they did was they looked at 6,800 charts for heart disease, heart failure, diabetes, and then a bunch of screening and prevention cases. And then if somebody at the center was wonderful, because if someone deviated from the practice guideline, they had to file something called a medical exception, right? And so there were 614 of these medical exceptions filed. And then an adjudication committee decided to look through these individually, because you had to type something in, I didn't follow because of this. And so they looked through all of these, and guess what they found? They found that 575 of those were appropriate. Right? So where physicians were not following guidelines, they were appropriately not following guidelines because of medical reasons. They were uncertain in 20 other cases, and 19 they deemed inappropriate. Now I'm going to show you why maybe these 19 inappropriate might not be inappropriate. I really can't say. I don't know those particular cases. But you can see that medical exceptions are something that the medical community accepts when you're when you were looking at a patient as to why you don't follow a guideline, right? A patient-related factor to not follow the guideline. So the good thing is that these medical exceptions, are often or sometimes incorporated into practice guidelines in some way. Maybe not explicitly in the guideline, but in some sort of process by which we actually look at whether or not people are following them. We can say, this drug is contraindicated. There is some sort of record somewhere that right, is probably an acceptable practice. And I know I saw a few people possibly shake their heads because that's why I put the word sometimes, the question mark in here, because I don't know that they actually make it in, right? But you can see how maybe this is something that can work its way in. But what if I told you that Mr. Laurie, our hockey player, is not just a hockey player? He's the first-round draft pick for the Montreal Canadiens in the National Hockey League. And for those of you who know hockey, this is a big deal, right? This person is a godsend and maybe our prime minister one day, right? Because we love our hockey players. Full disclosure, I never played hockey. I played rugby, which was really strange to my parents because it's like, what are you doing? We don't even do that in this country. So I don't really have a whole lot of, concern for Mr. Laurie here, but the Montreal Canadiens might, right? And that's really important. So, this is what I would call a potential non-medical exception, or what we call a patient social context. And what we were interested in, well, Okay, so let me go more into that. So what do I mean by that? Well, this is something where the clinician deliberately avoids using the guideline recommendation because he or she believes that this non-medical or social context, right, will if not attending to that context, is in some way going to result in suboptimal patient care, right? And I'm sure the clinicians in the room all have situations like that they had where they said, you know what, I know I should do this, but if I do it to this patient, because I know that this patient's going to go home and do something else, this seems like a bad idea, I'm better off just admitting them to hospital so that I can make sure, or whatever, right? The trouble is the literature gives little attention to the influence of these factors on guideline adherence, and in fact, the literature, in my experience, spends an awful lot of time trying to drive these kinds of things out of practice, right? So what we wanted to know is, can patients' non-medical context lead to non-adherence? So we did that. To do this, what we did is we went to three cities in Canada, Toronto, Ottawa, Hamilton, and we recruited as many emergency department physicians as we could. So we got 28 expert and 28 inexperienced emergency department physicians. We defined an expert as someone who has 5 years of independent practice. Why? I asked a bunch of physicians, I said, when did you feel confident that you could practice on your own? And they said, well, it's 5 years after I finished my residency. So that was our threshold. For the inexperienced physicians, I went after what we call our postgraduate 1 and 2 residents. Now, this was deliberate as well because we figured these are people who know the clinical decision rules. We know because we've taught them at this point, right? They have some practice in the emergency department, but they don't know them they don't have such a great clinical practice that they're happy to just freely do whatever they want. They really are still trying to do what they're told. So we decided to go with the early resident group. So the next thing we did is we came up with these 12 clinical scenarios, right, that were very, I'm going to say vanilla, right, but we randomized these participants to the 12 scenarios where some of them would include that context condition, right? What we did is that social context variable that we would embed it into the case, or just 6 cases where they didn't have it. And it was random, and then we compared like with like. Then we asked them their management decisions. Would you X-ray? Would you whatever? And we looked to see, if they follow the guidelines or not follow the guidelines in each condition, and of course we compared the rate of that between the two conditions, right? Context condition rate of adherence to the non-context condition rate of adherence. We used 4 guidelines, right? These are point of care decision algorithms. They're the Ottawa ankle rule, Centrum-McIsaac score for strep throat, CHADS score, the CHADS-2 score for whether or not you give warfarin for someone who has atrial fibrillation, and something called the Canadian CT head rule. And at the end of the survey, to make sure that this was not an issue of a lack of knowledge by the physicians, at the end of the survey we said, do you have familiarity with these guidelines? And in a handful of situations, people said, well, I don't know that one very well. We just threw that data out. Now, I'll tell you, we analyzed it with and without, and the results are essentially the same. But what I'm going to show you is this data tossed from the analysis, because I wanted to make sure that this was not an issue of a lack of familiarity. Give you the cases that we had. So we had 3 of the ankle cases, 3 head, 3 strep throat, and some atrial fibrillation. We knew what the guidelines were going to tell us to do, and then we created these variables which are all over the place, right? So one person was pursued by police. We had a pro hockey player that you saw. There was a civil suit when someone fell off a curb and was going to sue the store owner of the parking lot that they were in. Patient lives alone for a CT head. Where the person fell and they live alone, right? We had one, the chair of the hospital board. That was a key one that we tossed in. A patient with advanced Alzheimer's disease. When we get to the strep, these are very interesting, right? So we had a mother as a nurse who works in the emergency department, right? So, person comes in and, we know that patient's mom. We had family members who were recently treated with strep, and we had who was an anxious parent. So to describe that one in more detail, because that one was a lot of fun to write, mom comes in with screaming child with query strep throat. 2 more children in tow. Both of those kids came back last week. The doctor gave them antibiotics for strep throat. Now what are you going to do, right? You're going to say to this patient, I'm sorry, your other kids got something, but I'm not going to give it to the third one, right? We had a nurse who was leaving for an isolated community, so that was kind of a, well, maybe you give it to them just in case. And the other ones were, one was a vascular surgeon, patient was an alcoholic, and we had an unreliable patient, which was also really fun to try to define people what an unreliable patient was. And these ones were important because taking your medication here, taking it incorrectly here can be very dangerous. All right, so let's look at what happened. So we have our experts and our inexperienced group. So we have a rate of adherence at the top here, and the dark bar is going to be when we have the no context condition, i.e. everything is normal, you should follow the guideline, and when our context comes in. So the first thing is we had around 80% adherence, and I wish it was 100, but it's not. But we had 80% adherence in both the expert and inexperienced group when it came to just the regular, run-of-the-mill, fit-for-the-guideline practice. But when we actually introduce the context variables, you can see a substantial drop. And this was actually a statistically significant drop, and it was, the effect size on it was substantial, especially in the expert group here. So this was significant. They dropped from over 80% to somewhere between 50 and 60%. And in our inexperienced group, they dropped from around 80% to around, I think it was just under 70, I think it was 67%. And these guys are actually significantly different from each other as well. So what we're finding here is the expert physicians, both groups, when they encounter these patients that have these weird sort of things going on in their circumstances, were more reluctant to deviate from the guideline, right? And the experts were doing it even more so than the inexperienced physicians. And so if I can sum up a little bit about that, so I'd say the physicians were knowledgeable of the clinical practice guidelines. So that kind of eliminates that first part of Cabana where you're saying, well, no, they don't follow because they're not knowledgeable. And they apply them in typical circumstances, that 80%, right? But their deviations were deliberate. We forced them to be deliberate because we gave them scenarios that said, what would you do here? And in fact, I actually did some qualitative research as a precursor to all of this, and I sat down with them when I tested out these cases. I said, tell me what you do for this person. And every single one of them said, well, I start with the guideline. Start with the Ottawa ankle rule. But this guy here, I'm not really keen on the fact that, there's a lawsuit, because inevitably, I don't want lawyers calling and then we're doing ankle x-rays and getting pulled in. I better do it, right? So there were these situations in which, it was deliberate. They told us it was deliberate. And this influence of the social context, it appears to be learned because it's more pronounced in the more experienced physicians. Right? So what is that all going to mean, right? So, what does it all mean? First thing you have to ask yourself is this non-adherence warranted? Because if it's not warranted, then this entire conversation has completely different meaning, right? So we have to decide, is deviation from clinical practice guidelines for this social context warranted? If it's no, right, then we need to develop strategies to get them to adhere. And some of that might be communication with patients, because if these are issues that physicians are reacting to patients, then we need to have the patients understand, I guess, a little better that there's not as much of a benefit as they think there is, right? I don't like that idea because, I don't think ankle x-rays are so bad that you can't throw a few extra ones in. But for some of these things, we can't let the patient completely drive the decision to go on warfarin. It's kind of, that is a very difficult decision to make, right? So that's if we don't think this is warranted, then obviously that's where we go. But if we do think that it is warranted, right, we have to ask ourselves, well, when, right? Because all those cases I showed you, is it warranted to deviate from the guidelines because we have, the head of the head of our hospital board wants it? No, it's probably not warranted, right? So we have to figure out when, and if we don't know, we need to find out. Well, if we do know, we need to find ways to incorporate them into the guidelines because they're not in the guidelines, right? And if that's not feasible, we got to figure out how to teach physicians when it is appropriate not to adhere. And that, I think, is going to be the most difficult part right there, because it is being learned somewhere, right? But it's probably not being learned formally. It's probably part of some sort of hidden curriculum. All right, and I'll just end it there with a personal plug, and I guess I'll sit down.
Great, we have a few minutes for questions for our speakers.